As you know, we have already discussed about the prevalence and incidence of spinal tuberculosis, which presents with chronic axial pain, which can present with the deformities and disabilities, and especially when it affects the cervical spine or the craniovertebral junction, it can cause, sometimes it can be a life-threatening event as well. Both the adults and the children in the productive age group are affected commonly. So today we'll see some of the clinical scenario and some of the diagnostic dilemma, and how to initiate the treatment, what are the recommendation by the Index TB guidelines published by the Ministry of Health and Family Welfare, Central TB Division, and also how to decide upon the end of the treatment and a word on the MDR TB as well. So this is a usual reference letter we get when we are sitting in a NTEP unit as an MO, medical officer. The reference goes like this. Mr. X is a 46-year-old manual laborer who is a smoker and occasional alcohol abuser, came for evaluation of chronic backache. His CT shows destruction of the T11 and T12 vertebral disc with wet compression. His CSR is 67 in the first hour, and Mando is done. Please read the Mando and give your valuable opinion. At this point of time, I would like to talk about the test Mando, or the tuberculin skin test, or an equivalent is the interferon gamma release assay. In fact, these tests will not diagnose any active tuberculosis diseases. They are called the indirect tests, and this will suggest that there are some immune response to a previously exposed mycobacterial tubercular bacilli. Rather, you should be doing a direct test which can demonstrate the HZ bacilli either in the sputum or in the culture, or by demonstrating their genetic material, the DNAs, in the PCR-based nucleic acid amplification test. So, in this context, for this particular patient, Mando will not give you any clue regarding the diagnosis. So, IGRA and the Mando cannot distinguish between latent TB infection and active disease. So, in this particular patient, it doesn't have any value. So, the reply will be something like this. Many thanks for the reference. Diagnosing the spinal condition is not my area of expertise. Kindly do appropriate investigation to make a diagnosis of the same. If your clinical diagnosis is spinal tuberculosis, and if you feel that the patient needs an anti-tuberculosis therapy, we will be happy to arrange for the same. Please let us know. Based on this, the patient was diagnosed on a clinical grounds. So there are two types of diagnosis for spinal tuberculosis. One is a clinically diagnosed spinal tuberculosis. The other one is microbiologically confirmed spinal tuberculosis. Microbiologically confirmed spinal tuberculosis is when you have a tissue or an aspirate which is subjected for a culture or a nucleic acid amplification test like the CBNAT. When it is positive, we will call it as a microbiologically confirmed tuberculosis. In all other situations where there is an appropriate clinical history with a appropriate or the consistent radiological findings in X-ray, MRI, or CT, and or a histopathology of the tissue, we will call it as a clinically diagnosed spinal tuberculosis. In the previous speakers have emphasized the role of detecting the mycobacterium and confirming the diagnosis, especially when there are confusions or dilemma later during the course of the treatment. Plain X-ray cannot diagnose most of the tubercular condition, especially the early phase stages of the disease, and it may not be a very good test to diagnose spinal tuberculosis. But if you see the MRI of the spine, you can very well see the destruction of the vertebrae as well as an abscess formation which indents the spinal cord. So MRI has definitely a role, a higher sensitivity and specificity compared to these plain X-rays. So this patient was started on anti-tuberculous drug, but at that point of time, there was some confusion. Is it tuberculosis itself, or is it a malignancy, or is it a bacterial infection or a fungal infection? So commonly the immediate differential diagnosis of a tuberculosis is malignancy, especially the secondary deposits as well as the lymphoma, which affects the spinal cord, the vertebral column. So these are there. These confusions will be there if you are clinically diagnosing tuberculosis in spinal tuberculosis. So all the clinical diagnosis need to be confirmed by other investigations. MRI is a very good investigation. MRI scores over the plain X-ray and CT. We will come to that later. So index TB guidelines suggest that when a patient with localized back pain for more than 6 weeks, with tenderness on examination of the spinous process, with fever and weight loss, with or without signs of spinal cord compression, one should consider the possibility of a spinal tuberculosis. And in advanced cases, there could be severe pain, spinal deformities, and paraspinal muscle wasting, and progressive neurological deficit as well. In all these clinical setting, one should positively look for the presence of tuberculosis of the spine. So what should we do? What are the investigations that can be done? The first one is the chest X-ray. The index TB guideline suggests that you should do a chest X-ray in all patients with suspected or confirmed case of spinal tuberculosis, because there could be an associated pulmonary tuberculosis which can be easily missed if you do not take a chest X-ray. So in all patients, one should take a chest X-ray. And also, as for any other extra pulmonary tuberculosis, it is mandatory that an HIV test be offered. The HIV infection, HIV infection is common among extrapulmonary tuberculosis than pulmonary tuberculosis. And also, the role of this X-ray, we have already discussed that it is limited, but X-ray can be used as a tool for following up the patient later on. And about the MRI can pick up the early lesions of the spinal tuberculosis, and also it can suggest whether there is any neurological involvement, the compression of the spinal cord, etc. There are 7 or 8 signs which are specific for spinal tuberculosis, and combination of these signs can very well predict the presence of spinal tuberculosis. And about the CT is not routinely indicated in all the patients, but when you are planning for a CT guided biopsy or aspiration, CT is indicated. And also, when you are planning for a surgery, then CT may be very helpful in planning your surgery. Then biopsy of the lesion. If possible, all the patients should get a biopsy or a good amount of a chunk of tissue or aspiration for histopathology or cytology, and also for microbiological studies. Both smears and cultures has to be done. Though in China, which compares the diagnostic accuracy of the conventional microbiological test with the nucleic acid amplification test, and they have found that independently they have a lower sensitivity and specificity, but when they combine the culture and the nucleic acid amplification test like the gene expert and the histopathology, the sensitivity and specificity goes beyond the 90% marks. So combination of the culture, the microbiological, the nucleic acid amplification test and histopathology will give a better diagnosis over other single, diagnostic methods. So this slide has also already been shown by Anita Madam. What is our experience in extrapulmonary tuberculosis utilizing gene expert? This is done by Beena Madam et al. From Calicut Medical College, and it suggests that the cold abscess aspirate will have a sensitivity of around 40%. 40%, but the bone biopsy specimens are yielding less, to the tune of 12.5% or so. Still, when we have a specimen, it is better to send for the CBNAT test as well. So the key message is get the tissue or the specimen whenever and wherever possible, so that you can avoid many of the dilemmas during the initial diagnosis. So this Mr. X was started on anti-tuberculosis therapy, and after 2 months, his symptoms were aggravated. He has now numbness of both lower limbs and with paresthesia. The present reference was for considering the possibility of MDR-TB, since there were aggravation of the local symptoms. However, he had a prompt improvement of the constitutional symptoms. He has fever has subsided. He had gained weight, and also the appetite has improved. So at this point of time, we should consider the possibility of a paradoxical reaction. In paradoxical reaction, there will be an initial improvement, but later, after from 4 to 8 weeks, the patient can have a aggravation of the local symptoms. But it has to be diagnosed by excluding all other the possibilities, including the different diagnosis or the development of the multi-drug resistant tuberculosis. And this reaction may pose difficulties for the treating orthopedician as well as the whole treating team. So there are literature available for the clinical pattern of the paradoxical response in spinal tuberculosis. As you know that when you treat the patient with anti-tuberculous therapy, there will be an improvement in the immune system in the form of improved or increased lymphocyte count, functional in lymphocyte count, and these lymphocytes or the immune system may overreact to against the bacilli in an attempt to contain the disease. That may be counterproductive at times, and there will be aggravation of all the local symptoms. And this is a picture of the spinal tuberculosis. You can see that the D6, 7, and 8 vertebrae are affected. And after 2 months of treatment, in the middle panel, you can see that there is an increase in the swelling as well as the abscess for paraspinal muscle paraspinal abscess formation and indentation of the spinal cord. And this patient was continued on anti-tuberculous drug. And at the end of the 1 year, you can see that there is total clearance of the lesions and reasonable restoration of the skeletal tissue. So that's how it behaves. But this has to be done by the diagnosis of paradoxical reaction has to be done by excluding all other possibilities, which includes the multi-drug resistant tuberculosis. What are the anti-tuberculous drugs treatment available for spinal tuberculosis? Essentially, they are the same for any other tuberculosis. So we have the 4-drug regime for 2 months, that is INH, rifampicin, ethambutol, and pyrazinamide, and a 10-month regime, during a 10-month course of 3 drugs, that is rifampicin, ethambutol, and INH. So the duration of the treatment according to the index TB guidelines are 12 months. And if you feel that the spinal tuberculosis has not clinically resolved or radiological resolution is not poor, you can extend even up to 18 months of anti-tuberculous drugs. And when you are diagnosing spinal tuberculosis on a clinical ground, that is clinically diagnosed spinal tuberculosis, and then you have to refer to a team which contains an orthopedic surgeon, a microbiologist, and a pulmonologist, and a radiologist, preferably in a tertiary care center for coordinating the management as per the index TB guideline. This is to consider other diagnoses or the issues that can come across during the treatment and early tackling of the illness. So how are you going to follow up the patient? If the patient doesn't have any neurological symptoms or any other major symptoms, when the patient has a newer symptoms, either the local symptom or a neurological symptom, they have to come to the clinic, to the hospital as and when necessary. Otherwise, a weekly follow-up for development of other symptoms. And if the patient has got already developed a neurological symptom, you have to grade the neurological symptoms, and you have to frequently see the patient at least once a week for the treatment response, whether the patient is deteriorating or whether the patient is recovering from the illness. So repeat X-ray should be done at every 3 months following the initiation of the treatment. And also follow-up MRIs are suggested at 6 months, 9 months, 12 months, and at the end of the treatment if you are prolonging up to 18 months. So that is indicated. And even after the treatment, the patient need to be followed up 6 monthly frequency for at least for 2 years. So that is how the follow-up is planned. So a word about the multi-drug resistant tuberculosis in spine. Multi-drug resistant tuberculosis do occur in spinal tuberculosis, and that has to be positively diagnosed. When the patient fails to the treatment, then you have to take the samples for the microbiological culture, and multi-drug resistant tuberculosis is diagnosed by the microbiological method or by demonstrating the particular genetic, loci by appropriate tests. So, if the patient is not responding initially and there is progression of the disease, then you have to obtain the microbiological sample for testing and confirm the diagnosis. And multi-drug resistant tuberculosis is better diagnosed by a team of team for drug resistant tuberculosis. Usually there will be a team for each district, and they will take care of that particular patient. They will decide upon, sitting together, decide upon the individual patient tailored regimes. So to summarize, spinal tuberculosis should be suspected and diagnosed early. Timely use of MRI may pick up more patients in early stages. The interferon gamma release assays and Mando cannot diagnose active diseases. Whenever possible, get a specimen for micro or pathological examination. And the duration of ATT is 1 year, which may be extended to 18 months. And the end of the treatment is usually decided by the clinical resolution, which is that judged by the treating orthopedician and also by the radiological resolution. Thank you for the patient listening. Thank you.